Great. So today's webinar, titled Advancing Medicaid Health Equity and Quality Through Effective Communications, is brought to you by Usher in partnership with Rex Wallace Consulting. Usher delivers an AI-powered, HIPAA-secure, no-code customer experience automation platform that allows healthcare companies to educate, guide, and support members with omni-channel, interactive, digital self-service. Usher is also an MHPA Silver partner and a longtime supporter of MHPA and our health plan members. Rex Wallace Consulting is a strategy consulting firm with deep experience in quality improvement. They help clients improve ratings by leveraging industry best practices to create more meaningful and effective engagement, develop cultures of quality, and deliver business results. I'm excited to welcome today's presenters, Yvonne Doherty and Nate Lucena. Yvonne is the healthcare industry leader at Usher and brings more than 25 years of experience in healthcare via leadership roles in marketing and communications, including 6 years at United Healthcare in demand generation marketing, broker, employee, and member communications. Throughout her career, she has specialized in more effective and influential communications that drive engagement, better experiences, and better outcomes. Yvonne leads healthcare strategy and go-to-market at Usher, serving as the bridge between business and the market. She is also Usher's subject matter expert for member engagement and activation best practices, working with clients around the world to implement more effective omni-channel, B2B, and B2C communication. Nate is a senior consultant at Rex Wallace Consulting. Prior to his current role, Nate held executive analytics and strategy roles at Centene Corporation. Nate's roles include enterprise analytics and data science, enterprise quality performance improvement strategy, national vendor and budget management, and quality improvement business development for Medicare, Medicaid, and marketplace lines of business. His current work involves expert consulting and thought leadership on all aspects of strategy, program governance, organizational engagement, program evaluation, strategy planning, and leadership development with specific expertise in analytics, data science, and health equity. With all that being said, I'd like to thank them both for organizing and presenting today's session. And with that, I will turn things over to Yvonne.
Awesome. Thank you for saying all that without passing out, Eric. Really appreciate it. And thank you to everyone for being here today. We are really excited to share with you what we are seeing as driving successful communications and supporting and influencing these most vulnerable members to take better health and wellness action. So in order for all of us to meet business goals, these communications really have to be effective. Nate and I are really, really passionate about this topic, and we're here today to share our keys to understanding some of the root cause barriers to communication success and some proven ways to reach, motivate, and influence members. And what we're really wanting to do is give you some tools and tips and tricks to make your communications more successful as well. So today, we're going to cover the current state in health equity, quality, and member experience. Then we'll jump over to perceptions of healthcare quality and lack of trust and how they contribute to disparities, so some of the root causes. Then we're going to get into a bit more of the solution. So how can you improve access, engagement, and health outcomes with proper member targeting and proper multi-channel approaches? Then we're going to jump into some best practices that are actually helping communications be more effective to engage and influence this particularly hard to reach population. So I'm going to get us to the first slide, and Nate is going to walk us through the first part of this. So he's going to cover the current state, and then we'll look for your Q&A during this, and I'm going to hand it over to Nate.
All right, thanks Yvonne, and thanks Eric. Really excited to be here today and grateful for Usher for letting RWC tag along on this adventure. Before I kind of launch into this slide, you know, in addition to all of kind of my business dealings that Eric went over, you know, I do want to highlight I grew up in rural America, deep in the South. I am a biracial person of color. I identify as queer. I've experienced a lot of the things that we're trying to solve for in the healthcare system when it comes to health equity. I've seen them firsthand throughout the course of my life. I've seen them impact people in my families and people in my community. So when Yvonne says that we are passionate about this, certainly we're passionate about it. from the business perspective and helping our clients achieve their goals. But it's also a deeply personal thing, right? I believe this is the right thing that we should be doing, particularly in the Medicaid line of business, all lines of business, of course. But when we think about the goals of the Medicaid program and the really big hurdles that we have in this country for these problems that we're trying to solve for, this is deeply personal work for me. And I carry those experiences with me when I'm thinking about how to help my clients solve for all of these issues. So again, really, really appreciate this group and your mission and the opportunity to come talk to you today. Okay, so with that, let's really start to cover the current state of health equity and quality. So again, when I think about quality improvement work, and I've kind of always been this way, I don't really have a concept of quality improvement work without health equity and disparity reduction. Those are sort of the key levers in my mind that we really need to be thinking about when we're talking about improving the overall health of the community and reducing the health burden that our population level is experiencing. So certainly the focus of quality improvement in managed care specifically has really always kind of inherently dealt with disparity reduction, right? Maybe implicitly in terms of improving those overall outcomes. But what we've noticed, if you've been around in managed care long enough, is that this is becoming much more explicit over the last 10 years and is really accelerating over the last 5 years. Health equity specifically and disparity reduction have really kind of taken the center stage across Medicaid, Medicare, and Marketplace, really being codified into the rules for how these programs are measured and administered. And that is across our regulators and our payers and our providers as well. So really important. I think this is the right direction for us to go into, but it does present a host of difficulties, particularly around quality improvement and member communication. I want to spend some time on the CMS Health Equity Framework, which actually was just updated with a little bit more, specific information about some of these. So I'm going to spend a bit of time on this slide because I think it's a really helpful and impactful framework for kind of how we think about our health equity opportunities and activities across the next decade to kind of stay in lockstep with the priorities of our regulators. So this health equity framework really outlines the priorities for the next 10 years and seeks to align across lines of business this health equity focus. To me, that's the right thing to do because when we have our payers and providers kind of all focused on different things and they're not aligned, it really ends up with confusion and really this issue not getting the attention that it deserves. And ultimately, there's not a lot of efficacy in the initiatives pointed at it. So really, we're looking to attack disparities in all products and really build out this complete disparity reduction focused ecosystem that helps providers, plans, academic researchers, and product designs really foster the kind of disparity reduction that we're looking to see. So health equity priority number one, we have all heard the quote that you can't improve what you don't measure. And that is true in quality improvement. It's particularly true when you're talking about trying to understand what's going on in vulnerable populations and how that is systematically different than what might be going on in the population as a whole. What we know, and if you don't know, I'll tell you, is that our data is bad. Okay, you guys, our data is bad. And our data is systematically even worse in some of the very vulnerable populations that we are attempting to solve problems with and for. So that badness really just gets worse in communities that historically are experiencing this lack of access, the effects of discrimination, and high burden of social determinants of health. So standardized data from different types of patient assessments, enrollment forms, health risk assessments, et cetera. Those are really the things that are going to ensure that we're able to draw valid and reliable conclusions from the data just at the baseline when we're trying to identify disparities and measure the efficacy of the initiatives that we're putting into place. We're going to get into a little more detail about the current state of some of those efforts later. But for me, this is sort of the foundation of all of this work, not just for identifying the disparities, but all the way through, what Yvonne's going to talk to us about later in terms of pushing communications out to different types of members in ways that gets them the information that they need on the channel that will engage them. If your foundational data is bad, if certain parts of it are systematically missing in different groups of people, the conclusions that you're able to draw from that data are ultimately limited and could be pointing you in the wrong direction, right? So we really have to focus on this, and I'll show you some data later on that indicates that states are really focusing on this as kind of a foundational, core competency in operating. Priority number 2, assess the causes of disparities within CMS programs and address inequities in policies and operations. So when I think about health disparities, I think about all of the things that are arising from what people experience growing up in our society, right? So it's the culmination of all this different type of discrimination, lack of access, and things like that. But one really important component of that is how are our institutions and policies ultimately rooted in those discriminatory systems, and despite our best intentions, potentially perpetuating or even in some cases exacerbating the disparities in access and outcomes just due to how our policies and operational structures are defined. So, CMS is really taking a critical eye to this, and rightly so, I think. And so when we think about some of the flexibilities that CMS and Medicaid services are pushing out to payers and states, things like waiver programs in lieu of service programs, things like the VBID or value-based insurance design programs in Medicare and in dual eligible plans specifically, those are really aimed at pressure testing the way that we design our value-based programs to give a little bit more freedom to us to really focus some of the benefits that we're delivering on disparity reduction. So I think it's really important to understand what you're allowed to do. Potentially, if you're a quality leader and you're not at the table when benefits are actually getting designed, elbow your way in there. It's really important, particularly when we talk about quality improvement and disparity reduction as sort of these inextricably linked things, to make sure that you have a seat at the table and can determine how to leverage this flexibility to ultimately reach that disparity reduction goal. We also have to focus on the root causes of disparities in coverage and network adequacy, and provider availability, things of that nature, to identify and fix ways that care delivery is structured that, again, may inadvertently perpetuate those disparities. So priority number 3, we have to build out the capacity of our healthcare organizations and the workforce to reduce healthcare and health disparities. Our healthcare professionals are really best positioned to deliver disparity reduction kind of in real time at the point of care, but they might not be appropriately educated or resourced or incentivized to do that. And so we have to set up programs that identify what those best practices are and be able to scale them within the context of healthcare delivery. I'm going to skip over the 4th one because it's most relevant to the rest of what we're going to talk about today. But the 5th priority is that really health equity must include folks with disabilities. So rates of disabilities increase with age, we already know that, but they are higher in racial and ethnic minorities, so often comorbid with higher risk of chronic conditions that we see in those racial minorities, so further compounding some of the health disparities. So we have to ensure that all levels of care are equally accessible, yes, to minority populations, but those with disabilities. And that applies to infrastructure, the ways that we communicate, and the way that we deliver care. So let's hop back to this 4th one, because really this is going to really drive the conversation that we're having today. Advanced language access, health literacy, and the provision of culturally tailored services. So think about our population here. 9% of the general population has limited English proficiency. Over a third have low health literacy. We know that those numbers jump up in our Medicaid populations. So communication with patients and beneficiaries that is not culturally tailored, and I'm consciously not saying culturally competent because I think that is a bar that is far too low for us to be aiming for today, but culturally tailored at the right level of literacy has huge negative impacts on everything from clinical outcomes, member experience, utilization, preventative care. And you're going to hear, you hear it all the time. You're going to hear us say it today, talk to the right member at the right time on the right channel. We have to get more precise about what that actually means. And I think this is what allows us to do that. So CMS is really clear here also that the best solutions for this particular priority will come from stakeholders and community members who need help with health literacy, and they need that culturally tailored communication. Because that's the only way you're going to get them to feel safe and informed about the healthcare decisions they need to make. Okay, next slide. I'm not going to go over these in depth. They're here to really show you how the Center for Medicaid and CHIP Services is basically fully aligned with this CMS set of priorities. So we're achieving alignment, and that's good for all of us, less things to focus on. So this is kind of this focus on health equity is actually driving, practical activity within the health plan space. So the Kaiser Family Foundation, in the latest results of their survey, really found that the focus on health equity is growing in Medicaid. So when we think about the target or required initiatives to reduce disparities, these are growing in Medicaid states and really focused on things like maternal health, behavioral health, and chronic conditions. Those are the quality measures that have long been overrepresented in state quality P4P programs for managed care organizations. And now we do have evidence that this focus is getting a little more specific on the disparities that exist in those measures and a plan's ability to reduce them over time. I think we should be fully prepared that this trend is going to continue and grow. Next slide. So even though we have a higher focus on it, circling back to this data portion, many states are still struggling to collect this foundational race, ethnicity, and language data, particularly in Medicaid populations. The data on the right is a little bit old at this point, but I don't think that it's gotten any better in subsequent years. There are 17 states with more than 20% of Medicaid race and ethnicity data marked as missing and unknown. I think 4 of those states, MACPAC has rated their data as unusable. And this missing data is often more prevalent in some of our minority populations and most vulnerable at-risk populations. And again, that makes the ongoing measurement of disparities much more difficult, and it makes it harder to know if our initiatives are working. So disparities, despite this focus, we've had a long focus on disparity reduction. We know that disparities persist across clinical outcomes. This is not necessarily like traditional HEDIS measures we might think of, but you can see the data on where results are better, worse, or no different, or where there's a data limitation across our major racial and ethnic groups. And you can see that these disparities are persisting, and they do so across chronic conditions, behavioral health issues, things like blood pressure, diabetes, and obesity. And they also exist in access to primary care and sort of likelihood of using ED services, and also things like food insecurity. So really across the board. This is a similar view, but I just broke it out by male versus female. And really, this is here to illustrate to you the dangers of what happens when we don't have enough data to calculate a valid rate. You can see in the AI and AN group, those bars are a lot shorter because there's not enough data to calculate what regulators would think is potentially a valid rate for comparison. Some of that certainly can be due to the fact that not all racial categories have the same number of people in them, and that is even clearer when you start slicing and dicing things by geography. But if we don't make the effort to collect the most robust data set here foundationally, we're not going to be able to do this complex quality improvement and disparity reduction work. Disparities persist across, this should say member experience outcomes as well. So this is a map that I made of stratified CAHPS data in dual eligible Medicaid, Medicare populations. What you can see is white beneficiary responses across the top, and then Black, Hispanic, and Asian Pacific Islander in those subsequent rows. And what you can see is across every domain of the self-rated member experience, the outcomes are worse in the entire country or in large portions of the country in racial minority groups compared to their white counterparts. What you'll also see is large geographic gaps in the data, telling us that either one of two things is happening. There aren't that many beneficiaries of that particular race, ethnicity in that area, or they are not self-reporting their race at the same rate, meaning that we can't really understand what's going on in that population in that location. So this is a really important thing to consider. And then this is just showing that these differences in perception persist over time. So this is over the last 4 years of data. Again, this is only dual eligible CAHPS results. And you can see that some of these disparities persist and are even getting worse over time. So when we think about performance improvement solutions and our quality improvement solutions in our plan, those have to be developed through a disparity reduction lens.
Great. Thank you so much for going through that, Nate. Now we're going to shift into, now that we have the landscape and some of the root cause barriers, we're going to shift into the perceptions of healthcare quality and lack of trust that are also contributing to the disparity. So I'll turn it back over to Nate to cover this as well. You just get back.
Great. Thanks, Yvonne. So when we think about how we're going to go about reducing disparities in these populations, data is foundational, and today a lot of our organizations don't have the data. But what I have seen in working with my clients is even in organizations that do have that data, they might put a bunch of initiatives into place and have data completeness to be able to measure it. But what they're not spending time on is understanding how to communicate with those members and really develop initiatives and push out the information in ways that are going to engage people who do not want to engage with the healthcare system for lots of different, very valid reasons. So what we know is that access to care strongly impacts ratings of healthcare quality, and those ratings of healthcare quality are really our beneficiaries telling us, am I receiving the level of quality in my healthcare that I think I deserve and that I want? So there are different things like access to care and your relationship with your personal doctor and how they communicate to you that are strongly predicted of these ratings of healthcare quality experience. You can go on to the next slide. So we know that negative healthcare experiences erode that trust. So here's how we understand that when members are rating healthcare quality and healthcare experiences low, we know what that translates into in terms of their day-to-day behavior is that it erodes their trust in the healthcare system and healthcare providers and healthcare payers. Less trust also means less loyalty to those providers or payers. So what we know from the data is that 80% of survey respondents say they would not return to the same provider if they had an experience where they lost trust. 60% of consumers would switch to another provider for more trust and respect. And over half of participants have lost trust in their healthcare provider due to a negative experience in the office. But it doesn't just translate into experiences. We also know that trust is inextricably linked to clinical outcomes and behaviors as well. So we know that 2/3 of patients with high levels of trust always take their medications. And only 1/7 of patients with low levels of trust always take their medications. And then again, this bleeds over on the next slide into the degree to which patients are adherent to their treatment regimens and whether or not their chronic conditions are under control. So what we can see here is that feeling disrespected leads to 12% greater non-adherence rate and roughly a 10% jump in folks whose diabetes is not managed well. So what you can see is this complete picture where healthcare experiences, which we know experience disparities, lead to erosions in trust, and those erosions in trust have ongoing impacts to a member's likelihood to see their provider and how their clinical care is managed. So we know that these disparities in trust and respect are also driving healthcare experiences. So all the data we looked at previously was lumped across the entire population. But just like disparities exist in our HEDIS and CAPS outcomes, we know that there are disparities in trust in the healthcare system as well. So there are a couple studies we have highlighted here. So one from the University of Chicago that showed that 1 in 5 Black patients reported discrimination by a doctor. Just over 1 in 10 of Hispanic patients reported this, and less than 10%, or Black and Hispanic patients were 10% less likely to say that their physicians trust what they, as the patient, are telling them. There's another study by Deloitte that found that 55% of people of color have reported negative experiences, including poor listening, discounting of symptoms, providing incorrect information, cultural insensitivity, and not engaging with empathy. We hear this all the time anecdotally from folks, and these are the statistics that prove that that's happening at the population level as well. And almost most concerning is that over a third of patients of color have avoided care due to treatment by providers or office staff. And every single time that happens, it contributes to a lack of trust in the healthcare system. So what do patients want? Let's circle back to what CMS has told us, which is that the way we're going to solve these problems is understanding and listening to what the actual stakeholders want from their care. When looking at this same group of patients of color, over half of them say that they would forego more convenience, such as in-person visits in a closer location, in order to find a provider who looks like, talks like them, and is from the same community or has the same shared experiences as them. So that can involve things like concordant language, race, empathy, and then clear communication of important information on preferred channels. And even though that study was aimed at providers, this is just as important for payers when we're talking about how we're communicating with our members and asking them to do things such as preventive care, engaging with care management, and going to see their provider. So we have to build trust through learning what matters to our patients. And we have to do that through patient and culturally centered engagement in preferred channels to improve those outcomes.
Great. Thank you so much, Nate, for getting us through that. And the next thing we're going to talk quickly about is improving access, engagement, and health outcomes. Now that you have the landscape, you have some of the root causes, we're going to jump into how communications can be more effective. So I'll jump in and let Nate cover this.
Sure. Thanks, Yvonne. So this is a very simplified, I will say, schematic. I don't mean to insinuate to anybody that this is as easy as a straight line, because it's not. But these are approaches that actually RWC has worked in real life with Usher on and seen be very, very effective in Medicaid populations. And so, you know, what we start out doing, I'll say these first two things typically are happening a little bit in tandem, right? We have them one after another, but they kind of overlap, right? So really approaching how you're going to retool your engagement and communication strategies towards what your members want and prefer really starts with a current state assessment and targeting within your outreach strategy. So CAPS as one of the most frequent measures of the member experience, we have to go in there with predictive analytics and really understand what the key drivers are to a lack of satisfaction and a lack of engagement. We need to use those at the population level to generate predictions down to the member level that are informative and actionable. And then we need to take those predictions and segment out our approach to communicating with our members based on what those predictions are telling us about their likelihood to be satisfied or dissatisfied with their care, their likelihood to engage or not engage. Advanced in predictive analytics and this population segmentation for us is one of the only ways you're actually going to know if you're targeting the right people and be able to go back and measure whether or not that worked. It's also one of the only mechanisms you're going to have to be much more efficient and less abrasive in your communications. So concurrent with that, what we do are much more qualitative assessments of the organization and your strategic priorities. And then we use that along with the results of the predictive analysis to come up with a very highly tactical plan that leverages all channels that are possible at the organization to outreach to members. And an integral part of that segmentation is really trying to understand for each segment of members, what is the most effective channel going to be? Okay. This is an example of how we might go into a set of predictive results and decide what to do. So we have a CAPS example here, but if you have predictions at the member level for HEDIS or utilization or member churn, this would work, in roughly the same way. So across the whole landscape of predictive dissatisfaction, we'll have high, moderate, and low risk folks. And we'll want to have a different strategy for each of them. So for high risk, we can think of those as people who are really likely to respond negatively on a CAPS survey, probably due to negative experiences. What we'll do is outreach to them in a really intensive sort of white glove live way to engage with them and really find out the individual root causes for that member and resolve the issue in real time, which is a very important component of that type of high risk outreach. For our moderate members, they might be less likely to have the highest level of risk across your population, or maybe at moderate risk across several of the things you're trying to impact. But there's likely to be a much larger volume of them, which can make it really untenable for you to do that white glove outreach. So they might respond negatively to CAPS. You really want to reach out to them, but it's kind of cost and time prohibitive. So you can outreach in cost-effective ways, such as digital channels, which are much cheaper. You have to have the data, of course, but leveraging things like text, interactive bidirectional texting that is secure, emails where there is click through to services like appointment availability and things like that. Those are really those channels where you can still have a huge impact in your moderate risk group while keeping the cost down and making sure that you have some scale there. And then our low risk are likely to respond positively. You really want to just do an outreach to them and make sure that they know they have an option to give feedback on this particular survey in the lowest cost way that you can. So again, this is a CAPS example, but it can apply across any behavior you're trying to motivate. So here we kind of have a schematic, and I know there's a lot of boxes here, but don't get worried. This is really trying to illustrate to you all in pretty concrete terms what we mean when we say omni-channel approach. And Usher really, truly does have an omni-channel approach once your populations are segmented. So Yvonne, I wonder if you could kind of walk us through what we're showing here.
Sure, thank you. And really what we're seeing in Medicare and Medicaid is not abandoning the channels you're currently using. If you're reaching them through email, through a mailer, through collateral text, if you're reaching them through live agents, don't abandon those, but you can bridge to digital communications that are interactive, that are HIPAA secure, that can handhold and communicate what you need them to do in a more cost-effective way, in a convenient way, in a self-service way. And when they need to get back to live, that can actually be bridged. So you can take everything that goes into the digital channels, whether it's an email, a bidirectional text, and if they need to speak to someone live or they need to chat with someone live, bridge it back so we can do click to call. And one of the most important things about seamless data transfers here is make it easier for the members. don't make them repeat themselves. If they've already shared something with you in a digital channel and you get them over to a live agent, take that data and put it in the agent single pane of glass. That's really, even for me as a healthcare consumer, repeating myself over and over again is probably one of the most friction-filled things in the world. So we can actually solve this through more seamless, true omni-channel, where these channels are bridged together.
Yeah, totally agree. And just to bring it back to the health equity lens and disparity reduction, across each one of these channels in each of your sort of beneficiary pools, if you go in and assess whether there are disparities in the likelihood that you're going to have valid data on it one channel or another channel, really engaging in this omni-channel approach to make sure that you are communicating with your membership in the way that specific segment of the population needs in order to engage in the behaviors that we know are healthier for them. This can be a very, very powerful tool to help you identify and then address disparities for members.
Awesome. Thank you. Thank you for that. So now we're going to shift from what Nate just shared into some best practices to engage and influence hard to reach members. And what I am going to share is what I've really been developing and honing over my entire career. Communications that engage, influence, and motivate people to take an action. It takes a different approach. And what it really incorporates, tying it back to what Nate said, is know your audience, know what they need, know what to communicate them at the point in time that they need to do something. It includes elements of human psychology. We're communicating with humans, busy humans, humans facing hardships. There's a need for empathy. So we need to make sure that's incorporated, as Nate had said earlier. The need for simplification of messaging, simplification and education. I actually borrow from direct response marketing best practices with directive calls to action, and I'm about to share a bit about that. And then hand-holding. It's tough to navigate the healthcare system, even for those of us who know it like the back of our hand. We can actually handhold and help members do what we need them to do until they do it. So that's what I'm going to share, is just some best practices in doing this. And I understand this is a highly regulated industry. There's a lot of legal, there's a lot of compliance. This still works. This still works in managed Medicare, managed Medicaid. It just takes a different approach. So we actually, one of my executive directors of quality, we started working with the Medi-Cal plan. They said, we cannot support health quality and equity if we can't even get our members to engage with us. We can't even reach them, let alone get them to interact. And this is where we're actually jumping in and really helping them have an impact. So I'm excited to share some of this. The very first thing in this population is consider the transient nature and the limited technology that's available in Medicaid, the duals. You must reach them where they are with the technology that they have. So I'm going to just jump into some best practices here that are really working, and they're really driving not just interactivity, but interactions, behavior, as well as outcomes. So I'm just going to step through them. Again, tying back to what Nate said, targeting the right people at the right time via the right channel with the right message, and support and education. Very, very critical. I started this. This is where you have to start if you want to be effective. Considering the technology that members have available, primarily smartphones for Medicaid members. Meet them where they are. Allow them to communicate with you, whether it's live or digitally, easily through their smartphone. It's really important, especially with all of the scamming and all of the tricksters and things that are out there, is identify yourself and your brand. Allay concern about who these messages are from. Make people know this is from you and help them feel safe especially if you have a link or something that they need to follow. I am a personal care navigator. All of my family members are trained, do not click a link in a text if it doesn't look safe. So know that people are trained not to do that. Really, really important, going back to all of the things that members need and all that they're facing and all that Nate shared. Be sure what's in it for the audience is always in top of mind. You need to get things done. You need them to do things. You need them to fill out surveys. Make sure they know what's in it for them to do it. The more they know, the more they will be apt to do it. There is a general distrust of the healthcare system, as Nate had mentioned. Help by telling them why you need them to do this, why you need them to share. Really, really critical. Simple is better. Keep the messaging clear and concise. Design your journeys for simplicity of interactivity. Even though we're all in this highly regulated world, this can be done, and it needs to be really, really emphasized. This is something that I find is lacking a lot, including clear calls to action. If you need someone to do something, tell them. Tell them, be directive. People are more apt to do what you tell them to do. So if you're very soft and you don't have a CTA, it would not be unlikely for them not to do what you want them to do. So this is critical. Don't distract from that main call to action with extra links or extra verbiage. Keep it pretty clear and pretty honed in. Don't include extra links. Don't take them extra places. Keep them on the path for the communication that you're sharing with them at that moment. For survey campaigns, use psychological nudges to keep the member engaged. Progress tracker bar. You're used to those when you order a pizza and you see the pizza delivery. You can do the same thing in surveys. You can put encouraging message along the way. As they're in a survey, the more you do this, the more apt they're going to finish it and not abandon. Personalized messages, but don't include PHI and PII in channels that aren't secure. So there are ways, as we showed you all those channels, to get them where you can have the conversation that includes PHI and PII when it's needed. So the next one, be agile, deploy, analyze, figure out what's working, and then iterate to perfect outcomes. And a very, very common thing we're facing is common question, can this be planned in advance? When we are planning our communications and sending them to approvals, legal, compliance, the state, the county, yes, it can. It can be done. It just needs to be planned out. Don't lead to dead ends. Let members know how to reach you after a journey ends. Respond to relevant messages they send back. I see so many text journeys where a member responds and it absolutely goes nowhere. And some of those responses, we've analyzed them, they're really important. And so we have ways of helping you know what they're sending back. Consider what they might need next and proactively plan to cover them. Just think about what might happen after they do what you need them to do. This is kind of basic, but it's really important. No-shows for appointments of any kind are very, very high. And so we found that if you just allow them to reschedule when you send them an appointment reminder, if the time doesn't work for them, they can reschedule and then they're less apt to no-show. So just a little nugget that's really helping with literally any appointment, whether it's clinical or otherwise. As we said, it may take multiple channels and multiple touch points to reach the members. There's a lot of worry about fatigue. Are we sending too many messages? If you're targeting and getting the message to the right people, it's not annoying, it's supportive. So support seamless channel hopping, repeat, remind. Members are busy and distracted with many things, including basic needs like food, shelter, and safety. So they're focusing on those, and they may need a nudge to get them back. And this is just a little bit deeper dive into what you're doing with your, if I find a lot of plans are doing the outbound text messages. So I just wanted to dig into here about things that I'm dissecting and seeing are keeping those from being successful. Don't look like you're smishing. Don't look like you're spammy. Don't look like you're a villain trying to steal their identity. Allay concerns in your text messages, especially if your text message includes a link. So this is a little repetitive, but I just know so many of you are using text messages. I wanted to dig into this deeper. Use the number that's recognizable to the recipient. If you're sending a text, make sure it has an area code they recognize, or a long code or short code number. People actually Google a number to see if it's tied to you, because they don't want to get into an unsafe situation. Know that. Think about the number. Make sure they know it's from you. And then keep the messages clear, simple, concise. I'm going to reiterate the call to action. If you're sending a text and you need them to do something, make sure that's really prominent. Don't distract with extra language or extra links. And I covered the call to action. This is a really big one. We have to include opt-out disclaimers. The language is sometimes scary. And I know this means pushing the envelope and pushing boundaries and working in partnership between communications, legal, and compliance. It's really important not to make language scary, especially opt-out language. Put yourself in the shoes of your members if you're looking at it. And if you're trying to get them to opt in, be sure you're not really driving them to opt out. I see this so much. Again, don't leave a dead end, and don't, traditional text is not secure. So if you aren't in if you're in a non-secure channel, don't include PHI or PII. I just put a little definition of smishing. And I'm going to wrap this up really quickly because I want to get us to Q&A. I just wanted to let you know these communication best practices span journeys. When you're a plan and you're communicating to members, when you're a plan and you're communicating to providers you rely on to drive quality, or SDOH and community resources, this works. This whole thing that we've been talking about, the targeting, the messaging, the best practices in sales, enrollment, retention, redetermination, member service, quality, HEDIS, health and well-being, which is what we're here to talk to you about today, and then any other administrative things. I'm going to flip through right now really quickly. I've included some of the top areas that we're actually focusing on with our plan clients. I'm not going to go in them in the essence of time, but I'll get you the deck so you can look at those. Nate mentioned this is working. Our approach is working, and everything that we shared with you. I wanted to close us out with an example. This is a Medi-Cal plan that engaged us to really assess their current state, develop campaigns that work, and they were really, really focused, as almost all of us are, on redetermination. This was back last year, and they really needed to secure permission to contact digitally and gather contact information. They were focusing first on members that were the most non-responsive to their traditional channels and pulling in the Usher Secure Digital channel. And so we came in with our HIPAA secure channels that are interactive, and it launches really quickly. So we actually, from contract signing to first campaign launch, we were live with their first campaign for redetermination in 3 weeks. 362,000 of their members were contacted within the first 3 weeks of launch. And we learned after the fact, these are their absolute hardest to reach members. So they really, really loaded us with the hardest ones. In the very first campaign, the very first time they introduced Usher with the interactive secure digital, we exceeded their response rate goal by 200%. So these were unreachable members that they were now able to reach communicate with, and get them to take actions. So just wanted to share this with you quickly. And then I will jump us into questions and wrap up. I apologize we didn't get to them during, but we have reserved this time to go into the Q&A. So I'm going to just jump over there and look and see what we have in here. So we have one question. You might have already covered it, but what are some of the factors you incorporate when you're segmenting members, Nate? Is it a fixed list? Varies for each health plan?
So the short answer is we will take what we can get. So it is not a fixed list. Any variables that you have that can help us segment is what we will pull in, as long as we are sure that we can ensure the data integrity. However, to the degree that you have it, indications of their past behavior. So for HEDIS, that can just mean if they were in measures in a prior year, were they compliant or not. For CAHPS, it might mean, have they responded to a mock survey in the past, things of that nature. The past behavior is a really great prediction of future behavior. But also, wherever you have it, demographic data about members, again, to this health equity point, is really, really important and often can be highly predictive of behaviors, particularly when you combine that with location data. So we've all heard that, you know, X% of health outcomes or lifespan can be predicted by zip code. But we also all know that it's not the zip code that's predicting that, right? It's all the underlying demographic and socioeconomic and sociocultural variables. If you have access to those for your members, put them in the model. What I will say is predictive analytics, like a complex statistical model, will help you identify things that might actually move the needle versus things that are important but maybe unimpactable. But if you cannot build those models, if you can't go out and buy them, and if you don't have the internal resources to do them, you can still do this work. You go in, and whatever variables you have access to, you create a simple rubric. Is this present or is it not? Across the variables you care about, maybe you can weight them, and then you sum across that member and you prioritize that way. Based on root causes, you segment them out. Again, predictive analytics, statistical models, that's the gold standard, but you can absolutely do this work without doing that. So hopefully that's helpful. If you have other questions, certainly reach out to me and I can help.
Excellent. And I'll take this next one. It's related to the case study. So how did we obtain member consent to digitally engage if they were identified as hard to reach? So this is where that diagram of omni-channel really came into play. So we worked to figure out how can we get contact information. Some of the contact information came from the state or the county, but we drove them in from mailers with QR code. So you can do a mailer that has a QR code that goes to digital. And we've done several different things where you can have some language in there that, you know, going through to digital implies consent. Collateral, live agent talk tracks, live agent IVRs, really just anything that we could possibly do to get the contact information. And this is varies. We're working with many plans now in trying to get this consent. It really helped when the regs changed and we were able to get to these members without the consent the way it had been prescribed. But really just any way you can possibly get a hold of them or get a hold of a cell number in order to get a message out. So it's again, we made it look very simple in what we drew. This is hard. This is hard stuff, but we're able to really figure out a lot of different ways that we could do that.
Can I piggyback just for a second, Yvonne?
Sure.
So, you know, and Kristen, one of the ways that you can make that mailer to digital transition really, really fruitful is you'll notice it was kind of a small comment down there, but it was delivered in concordant language, right, to where the member had that on file. And we know from the research and the data that and Yvonne alluded to this in her best practices as well, If you explain to members what you're going to be doing with this data and why you need it and why you need them to do something at the level that is concordant with their health literacy, you can be way more effective at driving them to your channels. And there are folks like Usher who have expertise in how to craft that messaging to get that engagement. So like Yvonne said, it's a combo of making sure you really understand compliance and what you can do and what you can't, obviously. But then within that, really optimizing the construction of that message and the ask and being very clear on concordant channels.
Yeah, thanks for reminding me of that. We did so much, it's hard to even remember.
Yeah.
So thank you for Kristen for the question. And we have actually two questions that are similar. All of our language has to be approved in advance. How can we use these best practices and be in compliance with what our legal teams require? So do you want to take a first run at that, Nate?
I will leave that to you. You got the expertise there.
All right. So I will say this is absolutely one of the top questions that we have. And I've been in your shoes and I know what it's like to push the envelope with compliance and with legal who are looking to protect you, but still follow these best practices, have language concordance and incorporate all. It really takes being able to share a lot of what we're sharing. And really the thing that is setting a lot of our plans free is what they're doing now and the language they're using now and the channels they're using now aren't working. And they're not allowing them to meet important business goals. And so we're able to, Rex Wallace and team with Nate, we're able to make recommendations that you can take forward on how you could communicate differently and more effectively to compliance and legal teams. We're even sharing this with states and counties and getting the okay. We can do A/B testing, but really just getting the okay to try things differently. And this is so incredibly hard. Know that I know that. But those plans that are able to do it and shift are having better outcomes. And then those outcomes can be shared and allow more and more adaptation with future campaigns.
Can I ask a more precise version of that question,
Yes.
Yvonne? And then maybe I think we'll have to wrap it up. But
yes,
do you encourage plans? Do you kind of go in with them to understand the language landscape that they have ahead of time, and then maybe encourage to get all languages approved so that you can have them in your arsenal when you need to pull from them and use them? So that's to me the way that strategically during that assessment and member segmentation, you identify all of those in advance, and maybe down the road you decide maybe we're not going to send a text message to this segment of the population in this language, but you already have it if you need to do that.
Yes, absolutely. So we will actually also, and you do this as well, look at the current campaigns and look at these best practices, and we dissect and we pull them back together. And then we prepare that for the plans to send back for compliance review. So thank you for helping me kind of suss that out. So we are at time, and I want to respect everybody's time. And thank you all so much for being here with us, and really appreciate MHPA and Eric for hosting us. We will get you the slides. We will get you the recording. And again, we appreciate this and really hope this helps you to make your communications more effective. We know this is important, and thank you, and hope you'll all have a great day.